Today, we are recording the second episode of Trainee Pearls, a new initiative brought to you by the EBMT Trainee Committee. And today we have the pleasure to have with us Dr. Emma Groarke from the hematology branch of the National Heart, Lung and Blood Institute of the NIH, Bethesda, United States, to discuss about the recent research work on VEXAS syndrome published by the NIH group. Emma, first of all, thank you very much for accepting our invitation, and it is a pleasure to have you with us. How are you today?
I'm very well, and thank you for inviting me. I'm very excited to talk about VEXAS.
Thank you so much. I feel we are somehow celebrating the birthday of VEXAS because it's like about 1 year that the first paper in New England came out, right?
And yeah, I think it was the end of October last year where it was put online and then officially in December. So yes.
So pretty much like we are maybe celebrating
the anniversary, yes.
The anniversary of VEXAS syndrome. And I already see in PubMed 57 articles published on it. It's quite impressive, don't you think so?
I think so. And it's funny because, you know, every time the initial article gets cited, I get an email. So I wake up all the time like, oh, another citation. Oh, nice. But I think it's just really cool that, you know, that our paper has generated so much interest and so much, you know, work in the community.
Yeah, it has been really well received by the entire community, both hematologists and rheumatologists, immunologists, because it's like pretty much an overlapping spectrum kind of syndrome. But first of all, can you explain us what the acronyms stand for?
So VEXAS is an acronym that's derived from, I guess, particular features of the disease. So V is for the characteristic vacuoles that you see in the bone marrow aspirate. E1 is for the E1 ubiquitin enzyme, which is what UBA1 actually codes for. The X and the S stand for X-linked and somatic because it's an X-linked somatic mutation. And then the A is for autoinflammatory because that's one of the predominant manifestations clinically of VEXAS.
I see. So, of course, like VEXAS is also very appealing. Sounds very, a very nice and catchy name to remember. Could you tell us a little bit more about the pathogenesis of VEXAS, like the somatic mutation underlying these conditions? What happened?
Yeah, so I guess, you know, the way that VEXAS was discovered is actually quite interesting. So there was a researcher, so Dr. David Beck, who was first author on the New England Journal paper. So he works in the Genome Institute, and he was examining exome data from a genetic database of patients with undiagnosed inflammatory disorders at NIH. And he found 3 patients who were all male and had a variant in UBA1 that was new. And, you know, they all had a very similar clinical phenotype. So from there, he went on to find 22 more patients who had a very similar clinical phenotype and also had the same UBA1 variant. And then our team became involved really once it became apparent that some of these patients also had some hematologic manifestations. So the UBA1 gene itself is X-linked, as I mentioned. It encodes for this E1 enzyme, which is critical in regulating protein homeostasis. And the mutation in UBA1 leads to production of an ineffective isoform that results in loss of UBA1 function. And interestingly, when we were working this up, we found that the mutation is restricted to hematopoietic hematopoietic cells, as far as we can tell. And in particular, the hematopoietic stem cells and early progenitors, as well as mature myeloid cells and erythroids. But it's absent in mature lymphoid cells, which I think is quite interesting. And then further workup was done, and it was noted that patients had very elevated serum cytokines, and this includes CRP, IL-6, interferon gamma, and then gene expression profiling was done of monocytes and neutrophils of the patients that showed a highly activated inflammatory phenotype. And pathways were activated, including TNF, alpha, interferon gamma, interleukin-6. And then some of our collaborators at NIH developed this zebrafish model of UBA1. a knockdown of the zebrafish UBA1 model also showed that the zebrafish were developing systemic inflammation. So I guess overall, it appears that the mutated myeloid cells are somehow driving inflammation. It's not 100% clear, why this is the case. And I think there's a lot more work that still needs to be done, but that is kind of the general pathophysiology as we know it at the moment.
Thank you. So you mentioned inflammation, IL-6, CRP. So what all these generates as to clinical features, hematological and extra hematological, of these patients with VEXAS syndrome?
Yeah, so I think patients with VEXAS syndrome, first and foremost, have a very severe systemic inflammatory disorder. It's usually progressive and often treatment refractory, except to very high doses of steroids. And from an inflammatory point of view, I'd say that the common signs and symptoms that we see are recurrent fevers. A lot of patients have skin lesions. They can get chondritis, particularly ear and nose chondritis. Patients can also get pretty bad pulmonary infiltrates. But really, the inflammation seems to be able to target lots of different organs. And as you mentioned, there's all these things on PubMed where things are being really reported every few days, a new systemic manifestation of VEXAS. So I don't think we've really seen the full heterogeneity of the condition as of yet, but that's what we've seen to date. And a lot of these patients have received rheumatologic diagnoses before we knew they had VEXAS. I think the commonest was probably relapsing polychondritis, also Sweet syndrome, and different forms of systemic vasculitis as well. And then I guess in terms of the hematologic conditions, which I guess we'd be more interested in, so we do see that most patients have cytopenias of some kind. The commonest is macrocytic anemia. I think the majority of patients have some sort of macrocytic anemia. We've also seen lymphopenia in the majority of patients, although this is hard to tease out because they're all on immunosuppressants and steroids. We've also seen monocytopenia in a lot of the patients, around half of them. And a lot of patients can actually develop quite severe anemia that becomes transfusion dependent. And this is even in the absence of actually developing MDS, which is another risk with these patients. So hematological malignancy appears to be common in these patients. The commonest are MDS and plasma cell dyscrasia so far. We have a paper that was published in Blood Advances a few months ago where we did really deep clinical kind of hematologic phenotyping of 16 patients that we saw in the hematology clinic at NIH. And they all had bone marrows and had a full hematological workup. And of those patients, 6 of them had MDS, like overt MDS and morphological dysplasia. Most of those had cytogenetic abnormalities. We had 2 at MGUS as well, and also 2 that had full-blown myeloma or smoldering myeloma. And I think something interesting about the MDS is that to date, most of it seems to be low-risk MDS. All the patients at NIH that we've seen so far have had low-risk MDS. We haven't seen any transformed to leukemia or have chromosome 7 abnormalities. Now, there are a couple of cases in the literature where there have been a couple of high-risk MDSs reported. So it does seem it can happen, but it doesn't seem to be the predominant MDS phenotype that develops. I do think it's really interesting that there has always been this kind of clinical association between MDS and inflammatory disorders and autoimmune disorders, and that VEXAS, probably does account for some of those historical diagnoses. And I know even myself as a trainee have seen patients that I think back now, oh, it may have been VEXAS.
Yeah.
So I think it's really cool.
Yeah.
Yeah. And then I guess the other big thing is the plasma cell dyscrasias. I think we have less data on these so far. There's not a lot in the literature about this. From what we've seen in R4, we did see that I think 3 of them did have translocation of 11-14, which is a bit uncommon in untreated myeloma, and also increased expression of cyclin D1, which isn't all that common either in myeloma. So that seems to be something that, might pinpoint towards VEXAS. But again, this is like 4 patients, so we really can't make major comments on this. But this is something that we're really interested in looking further at, more about the myeloma phenotype in these patients. I think something really interesting about the fact that they do seem to develop myeloma is that the UBA1 does not seem to be present in the mature lymphoid cells. So it's kind of unclear why they're developing myeloma. So I guess our hypothesis on that is maybe it's some kind of, environmental thing, in the bone marrow that the UBA1 is driving myeloma potentially. But either way, I think it's a very interesting area that definitely needs a lot more study. And then I guess the final thing I want to highlight that I'm particularly interested in myself is the thrombotic risk in these patients. So in our cohort, we had around 16 patients. We had 60% of them had some sort of clot. Most of them, it was VTE, mostly DVTs, but also PEs as well, but one arterial stroke. And I guess the reason why this is happening, again, we don't really know, but hypotheses would be that it's related to the severe inflammation that these patients have. And we have been doing some very basic workup of what we were able to do in the coagulation lab. And in a few patients, we did do factor levels, and we found that the factor VIII's a bit high in some of the patients. So this may point towards inflammation driving the thrombosis. The other thing we've noticed that I thought was interesting is a lot of the patients, around 50%, seem to have a positive lupus anticoagulant.
Oh, wow.
But they don't have positive anticardiolipin or beta-2 glycoprotein antibodies. So it seems that there may be something antibody mediated going on, but not like clear-cut antiphospholipid syndrome. And then the final thing just about the thrombosis that we are considering is that there is this netosis that's been shown in patients with VEXAS. And we know that that's something else that could contribute to thrombosis. So that might be something else that's worth exploring as well, and into why these patients develop thrombosis. So overall, I feel like VEXAS is like, it has something for every hematologist, basically, benign, malignant, if you're interested in kind of plasma cells or myeloid malignancies.
It's very chameleontic, how can we say it, right?
Yes, yeah.
Well, and it's also the fascinating part of it, if we want, because of course, like there's so much to tell, so much to study, and that's the beauty of it. But according to what you've just said, depicting the clinical phenotypes of this patient, which patient that will present to your outpatient clinic, for example, with like a syndromic, with these syndromic features, will you consider to test for UBA1 mutations? All MDS, all plasma cell dyscrasias, or only selected categories, maybe with these features that resemble these the VEXAS syndrome features?
Yeah, I think this is a really good question. And this is something that we haven't really figured out ourselves yet. But I think what we're doing at the moment is that any male patients, again, it's X-linked, so these are predominantly men, although there is a case report of one female that has it, that had Turner syndrome, but generally it's men that get this. So a male patient who has MDS or MGUS and some kind of overlapping inflammatory phenotype is someone that I would be considering testing. Also patients that, they don't have to have MDS, but if they have some kind of cytopenia related to inflammation, I would probably test them as well, particularly macrocytic anemia. That seems to be the predominant cytopenia that would concern me. If patients are having marrows for some reason and you see vacuoles in the marrow, I think this is another important indication. Now, there are obviously other causes of this, but if you don't have a clear cause of vacuolation, I think you should test these patients for VEXAS. And I think with MDS, most patients will have a marrow, and you may be suspicious looking at the marrow that you see the vacuoles, although there have actually been, a couple of cases that don't have vacuoles. So it's not 100%. So I think if you have inflammation and MDS together, you should send it, even if you don't have vacuoles. But most of them do seem to have vacuoles. I think with MGUS, it's a bit trickier because I think a lot of these patients don't have marrows. It's commoner to have MGUS than MDS. And you don't want to be testing every single MGUS patient for UBA1, I don't think. So I think at the moment, I would advise, if you're suspicious based on the clinical phenotype, some kind of inflammatory, symptoms or something like that, I would consider it. Myeloma, we maybe with the T1114 cyclin D1, that might be a marker, but I don't think we know enough about that yet. But again, if you're seeing vacuoles in a marrow with a patient with myeloma, or they have some other inflammatory phenotype, that's when I would consider it. I do think ultimately that UBA1 will probably be added to the myeloid gene panel, and it will probably end up being done in most MDS patients, but it's not the case at the moment. It can be somewhat tricky to get testing for a lot of people still. We do offer it at NIH. If people are concerned about VEXAS, they can contact NIH and we can organize testing free of charge. For people who are based in Europe, it's also being offered in Leeds in the UK. So that's another option for European doctors to send testing. In terms of patients who are presented to a rheumatology clinic, I think this is another question that we've been asked. And our rheumatologists did publish a paper pretty soon after the original New England Journal paper, where they looked at their cohort of relapsing polychondritis patients. And they found that having macrocytic anemia really very well predicted for VEXAS in that cohort. So they're really advising that, for rheumatology patients, if they have macrocytic anemia, that is something you need to consider VEXAS syndrome.
I see. Thank you. So now that we more or less talked about the clinical phenotypes of this patient, let's move on the therapeutic strategies. Of course, we're talking about hematological, extra-hematological manifestations. So maybe let's narrow down to the hematological part. That is like what interests us the most. Do you have any advice on specific treatment for the hematological manifestation? And is it important, in your opinion, to play in a unite front together with rheumatologists, immunologists, in order to have the possibility of exchange opinions and share thoughts with our colleagues in a multidisciplinary team?
Yeah, so I think first of all to say that treatment for VEXAS is in the very early stages, so we really have very little data to go on, and most of what I'm saying is coming from very small case series reports, unfortunately, and hopefully that will change. That's something we're working on at NIH, developing clinical trials for patients with VEXAS, but at the moment we don't have a lot to go on. So I think that the way we're generally approaching it is that there's kind of three aspects we need to consider. So one is trying to eradicate the clone in some way. So, by doing that, we would hopefully, both get rid of the ongoing inflammation and also any potential hematologic manifestations that might develop and neoplastic consequences. So that's approach number one. Approach number two are therapies that target inflammatory pathways specifically, as the predominant feature of VEXAS is inflammatory. So that's something very important. And then three would be supportive care. So there are some important things to consider here as well for VEXAS patients. So in terms of targeting the clone, I think the two main approaches here would be either some sort of stem cell transplant or some kind of medical therapy that's cytotoxic, or a synthetic lethal drug therapy to try and target the clone. I guess theoretically, there are a lot of drugs here that you could consider. There is really very little evidence for any of them. The only one that's really been published at all is azacitidine. So there's been two publications using azacitidine, and in those publications, the response rates were around 50%. Now, patients who received azacitidine, for the most part, all had MDS or some sort of myeloid malignancy, and they did seem to respond, and around 50%. But I think the other interesting thing with the azacitidine is that a lot of the patients also seem to respond from an inflammatory point of view to the azacitidine. So it was, it helped their hematologic manifestations, but it also seemed to help their inflammatory manifestations. And that's probably because the clone was being targeted. So I think that's an interesting therapy that we're definitely interested in looking at more. For the inflammatory symptoms, the predominant therapy that's being used at the moment, and that does have some evidence in the literature, are JAK inhibitors. So there's been a couple of publications from the French group about this, and they seem to be somewhat efficacious in controlling the inflammatory symptoms. But again, most of the temporizing anti-inflammatories that are used, they do seem to work for a certain period of time, and then patients will relapse and end up needing to go back on steroids. And then in terms of supportive care, I think an important thing to consider here is that actually the patients seem to be at very high risk of opportunistic infections, probably related to the high dose steroids that they're on. But also, our rheumatologists think that compared to other patients who have rheumatological conditions who are on long-term steroids, that these are worse. And there's been a couple of patients that developed PJP, and for that reason, we do give PJP prophylaxis to patients. We give antiviral prophylaxis with valciclovir. And I think another interesting thing just to mention, not something that we're doing, but I think something we need to consider is some kind of thromboprophylaxis, just given the high VTE rates. There are other diseases where that's done. One that I can think of offhand is PNH in the pre-eculizumab era, that patients were anticoagulated due to a very severe risk of thrombosis. And the other one is myeloproliferative neoplasms as well. They have another high risk. So it's not unprecedented in hematological disorders to do this, but I don't know if we have enough evidence yet to kind of devise a way to do this. But I think something to consider in the long term, that we might need to consider this.
Probably the more patient we will be describing in the literature, the more we will know, and maybe we will have some kind of risk stratification in order to advise any treatment strategy, also prophylactically. So regarding the first strategy, the one targeting the clone, you mentioned the role of hematopoietic stem cell transplantation in this setting. So where do you envision the bone marrow transplant in the therapeutic arsenal for VEXAS syndrome?
Yeah, so I think allogeneic transplant is a very attractive option theoretically, because it both eradicates the clone, but also replaces the immune system in these patients, which we know is a major cause of disease. So, and just to say here that we do have a transplant protocol opening at NIH very soon. So a lot of this will probably be colored by what we're going to be doing. Which I will talk about. But I think the key thing here with allogeneic transplant is that it's attractive, but it should be used in a very select group of patients. So most VEXAS patients are old, unfortunately. So usually in their 60s and above is the common age group in this, in this disease. And we know that with age, mortality with allogeneic transplant, unfortunately, increases. The other thing is a lot of these patients may have been quite sick for years with their disease. They're, as I mentioned, on high dose steroids, and they can be deconditioned. So, the patients may not be in the best condition going into transplant. So I think that's something we need to consider. That said, I think there are good transplant candidates, and there are patients who will benefit from transplant. And I think these are the patients that we need to, carefully select. In terms of who would be transplant, so I guess I'll tell you what we're doing. So I think, patients who have severe transfusion-dependent anemias or myeloid neoplasms, that's pretty straightforward. They would have been probably transplanted even before we knew they had VEXAS, and some people, and that has happened. So I think that's straightforward enough. If they're fit, that would be a good indication. On our upcoming trial, we are actually also including patients with an inflammatory phenotype who don't have severe hematologic manifestations, but are refractory to all treatment. And this is because we know that patients with VEXAS have a very high mortality, and that this may be the only treatment, if no other treatment is working, that this may be the only chance to eradicate the clone long term. So that is something we're considering, although our plan is initially to try and enroll patients that have more of a hematological phenotype first, and treat those patients initially. I think myeloma is another tough group. So we're actually planning not to enroll patients with myeloma on our trial. The reason being, as you know, that patients with myeloma tend to do poorly with allogeneic stem cell transplant. But we don't really know in VEXAS whether that's the case or not, but just for the beginning, we're not planning to enroll them. And at the moment, most patients with myeloma who have VEXAS are being treated with standard myeloma therapies, which often which may include an autologous stem cell transplant. So in terms of like, what is the evidence for stem cell transplant in VEXAS, there's only been one publication so far, which had 6 patients, all of whom had VEXAS, but also had MDS, and one had myelofibrosis. And the conditioning that they used in the majority of these patients was actually fludarabine and busulfan, and most of them got reduced intensity conditioning. And the results are actually generally pretty good in this published cohort anyway. So they have long-term-ish follow-up in 3 patients. They're all doing pretty well. 2 are doing well in the immediate post-transplant setting, and 1 died of infection of pneumonia. I think one signal that does seem to be popping up from this case series is that 5 of them did have GVHD. So that might be a concern for our patient cohort going forward. And the plans for our protocol, we are going to use fludarabine and busulfan. And the reasons we're going with this regimen are really twofold. One is that it's a regimen we use a lot at NIH, so we have a lot of institutional experience using it. And secondly, it's also demonstrated pretty good efficacy in other monogenic germline diseases that are somewhat similar to VEXAS, not exactly, but things like DATA2 deficiency and DATA2, but there's also a very strong immune component to the disease. This regimen has proven efficacious. So we'll see. The protocol is open. It hasn't enrolled patients yet. We're still doing some last minute things in terms of regulation, but we hope to be up and running in January. That's the plan. And there are definitely other patients who have been transplanted in the community that we've been contacted about and seem to be doing well. So I think it is a promising treatment for, as I mentioned, a select group of patients, hopefully.
I see. So now let me ask you a more practical question. Let's change the topic. Let's give us some advice to trainees listening to this video podcast, whatever we want to call it. But if you had to choose to give 3 suggestions to our fellows who would like to begin a research path or become physician scientist, what would you pick?
Yeah, I think this is a hard question. Maybe I'm better talking about VEXAS, I don't know. But I'd say
I exhausted my question for VEXAS, I'm sorry.
I would say, I think number 1 is you have to, like, if you want to really become a researcher in a topic, it has to be something that's interesting to you, right? You're going to be spending a lot of your life thinking about this topic. You're going to be going to conferences about this topic. You're going to be spending nights reading about this topic. So it can't be something that bores you. And I think, there is obviously an element of picking something that would be a good niche, but I think it also has to be something that you are happy to devote your life to, in terms of research. I think that's number 1. I think number 2 is finding the right environment. And I know this can take, a couple of different tracks. I think, finding someone to mentor you is very important. But I think also, your colleagues within the department are very important. And I have found that since I came to NIH, like we have an amazing lab that, we collaborate among ourselves all the time. We bounce ideas off each other and often, complete projects together, even without necessarily, having everything go through the PI. So I think it's important that you have good colleagues, that you feel comfortable sharing things with, that you can collaborate with, that will help you with your research. I think that's very important. And then I think number 3, I think it's also important to make sure you advocate for yourself. So I think it can be difficult being a trainee. Sometimes in a big lab, there's lots of maybe other postdocs or other clinical fellows in there with different projects. I think you need to make sure that you have a project that is your project, depending on your level of seniority, but you're there for a purpose, right? You want to learn how to research, but you also need to progress your career. So I think it's important to advocate for that, make sure you've got a good project, that you're being supported well with this project, and that you're given right credit for your work, that you're allowed to present your work and all that. So I think those are the 3 main elements. There's probably other things that I'm not thinking of right now, but I think those would be the three that come to mind when you asked the question.
I think that were amazing suggestions for our fellows, and I think I can totally relate to all of the above. Yeah, interest, environment, either macro and micro, and yes, absolutely, and not falling in the trap of being a drop in an ocean. That's absolutely important. Yes, yes. So I think for today we can wrap it up, and I really thank you. That was such a nice conversation on VEXAS syndrome. I hope that everybody knows now a little bit more about this fascinating disorder, and we will meet again for a third episode of our Trainee Pearls. Thank you so much, Emma. Bye-bye.
Well, thank you so much for having me.